Either whichever sequence you do it, put a trial insert followed by the actual insert, or put the actual insert and then reduce the knee. Whichever way, I think it's always wiser to turn our attention, clear all the cement residue from the back of the knee, because you don't want to land up with an X-ray like this, which can have potential cement particles break off and cause subsequent problems. Another classical X-ray, can somebody read this X-ray and tell me what's the obvious problem? This patient presented a few months after the replacement. Somebody can dim the lights, that would be better. But I think you can appreciate what is the problem here. Symptoms of the medial aspect of the knee, about 6 months post-op, 7 months post-op. There were 2 instances of this happening, and the company people and we were not clear whether the locking mechanism was not properly deployed or subsequent backing out of the pin. But I thought I do share this with people who I come across, just to ensure that whoever's using, I use Biomet, in fact almost close to nil, but just make sure that the locking mechanism of the plastic insert and the pin is locked in properly. We don't know why this happens, but I thought everyone should be kept in the loop as to the possibility of this happening as well. Another example is another implanted with the back to the front. So basically the posterior was put in anterior. It's it's possible for this to happen because the center post in the INOR knee is not something that can easily be differentiated from the front to the back. So this is one of the X-rays that we photos we picked up at revision, where the posterior aspect was implanted in anteriorly. So now just to again teach us or make sure that all of us, it can happen to anybody, it can happen to all of us. I think we should be aware that when we put in the tibial trays or the implants, it should be looked at, we should be putting in the correct size, definitely not front to back in these days, but at least be aware of the size that goes in and all the other things that happen. This is not, again, a scenario that summing up of the medial side, asymmetric opening. What are the possibilities? Over-release, exactly. So there are 2 issues with this. One is, you can look locally itself as to an over-release on the medial collateral ligament side, or you can look, sometimes this can happen in subtle degrees if there is an unnoticed proximal femoral external rotational deformity. So I think these are possibilities we have to bear in mind. And the message has to be driven clear that over-release always has its problems. So the whole thing externally rotates. You will not be able to compensate this issue even with the thickest insert. And these are all. So these are just a couple of cases that I thought I would share when we have time. I think
the insert sitting out and how you explain it. So I think the prudence is that we have to be very, very careful. And surgery is your signature, surgery is our signature, and it's not a light-hearted job.
Yeah.
So that's the most important. Dr. Anil has significant.
What Dr. Anil, we should not do all this. But it happens.
It happens and it gets.
So my idea, maybe I could.
But the repair should be with augmentation. If you don't augment the repair and you don't protect it, you're going to lose it. So if you've seen where you've actually erased it off, the immediate solution is repair with augmentation and definitely protect the knee, which means you have to put it into a hinge knee brace and carefully mobilize the lead for 6 weeks at least.
Perfect. But what I need to say.
Correct. That's why I put up the
That is my idea.
Very good, sir.
That was the most significant thing, that first you must know what can happen wrong, then only you can prevent it by operating.
This is just to increase awareness. Even the poly X-rays I put up, basically because most of us do the poly impaction and then think everything is okay. But it's just that to remind everyone, for everyone's benefit, that the poly insert, locking mechanism has to be doubly checked, whichever company you use. I think it's always wiser to do that.
That's perfect, because after seeing the X-ray, everyone will check twice that whether it has been locked or not. And this purpose is served. Perfect. But I'll just tell one thing about religious. I showed my knee replacement technique. It was all stepwise. I can tell you, friends, I do most grotesque deformities, which we all do because we live in India. I never do any release. No release is required if you simply restore the anatomy. That's all. ligaments cannot be lengthened, they cannot be shortened. The only thing we have to do is to release the adhesions which has come over the time. A small cases of long-standing deformity with lurch can lead to lateral collateral ligament stretching out. That's all.
Where is deformity? See where is deformity. When you flex, there is no deformity. So why you are going to release the ligament? Whenever there is a contracture is of muscles, never of ligaments, as Dr. Prasad said. So never release too much, because we don't find any deformity in flexion.
Hip arthroplasty versus uncemented hip arthroplasty. The speakers are Dr. Hemant Sharma and Dr. IV Reddy. To start with the proceedings, now may I call upon Dr. Hemant Sharma and Dr. IV Reddy. Please come on the stage. Everybody outside is requested to please come inside the hall. Dr. IV Reddy will speak upon uncemented first, and then followed by Dr. Hemant Sharma, who will start the debate on the base of the uncemented things. Whatever facts are given by Dr. IV Reddy on uncemented, they will be confronted upon, and everybody will be welcome to interact in between. While the second talk by Dr. Hemant Sharma is there, the talk will be interactive, and in that talk the whole debate will be there. The time allotted is 30 minutes, and we will try to shrink it, because the actual debate part is now being changed to this kind of debate. So we'll try to shrink all the things to about 20 minutes. We start with the proceeding. Dr. IV Reddy, please come on the stage.
At the outset, I would like to thank the organizers for giving me this opportunity to be in front of you and sharing my views. So today's debate is on cemented versus uncemented, that's what I was told, and I am assigned the uncemented totally part of it. And in my opinion, debates are very good in that they will bring out the strengths and weaknesses of either technique. It's not that one technique is completely superior to the other one. We must learn both the techniques. Depending upon the case, we have to choose the appropriate one for the particular situation. It's not that I will do all the time uncemented, or it's not that I will do only cemented. An intelligent surgeon will learn either technique, and depending upon the presentation in a given situation, he will choose which one will work better in a particular case. Coming to the debate itself, mine is uncemented. The chief strength comes to me in the very fixation that is achieved by uncemented technique. If you leave that apart, there are a lot of positive things on the cemented side as well. So my debate, mainly the strength of my debate comes from this particular aspect. I would like to say a few points about this uncemented technique of achieving fixation of the implant in the bone, and then we'll proceed further forwards. So uncemented fixation, in contrast to cemented fixation, is a biological fixation. Implant fixation to bone is by osseointegration. So directly bone grows into and onto, depending upon the technique, and it will have a permanent bonding with the implant. And it should last for several years indefinitely, unless something happens like osteolysis, which is technologically limited. The present technology has its own limitations. A time will come there where there will be some amount of osteolysis, which will lead to aseptic loosening. And in case of uncemented fixation, better stress loading of the bone is supposed to be there, and bone also undergoes constant remodeling depending upon the stresses that are applied to the limb, and accordingly the fixation should go on indefinitely. So this is just to show the difference between the cemented and uncemented. In the case of cemented, between the implant and the bone, you have got this cemented cell, which is, in my opinion, at least in certain situations, is weak. So a few words before we go further about porous coating. You must know this technique, I am sure all of us, this particularly for the youngsters. It is achieved by sintering beads onto the substrate. That's one technique. The second technique is diffusion bonding of the fiber mesh. Either way, you are aiming for an optimal pore size of 100 to 400 micrometers. That will facilitate or invite the growth of the bone onto the implant. Other techniques, you have to understand the two technical aspects. One is ingrowth and the other is on-growth. Ingrowth is in porous surfaces, whereas on-growth you will get with what is called grit blasting or plasma spraying techniques, and also when you have hydroxyapatite coating. Here, the depth of penetration of the bone will not be that much, only about 5 to 8 micrometers, whereas in case of porous, depending upon the pore size, the optimal, as I said, up to 100 to 400 micrometers. Selection of implants, as far as it's concerned, according to DOS, we have got A, B, C. A and B are good for uncemented. C probably because it is very osteoporotic, you can think of going for cemented. I don't want to go into the details of these things now. It might become irrelevant as far as the design and other things are concerned. Basically, in case of cementless stems, there are tapered, cylindrical, anatomic, and anatomic are not that popular nowadays because of the thigh pain and other things. On the acetabular side, the best possible cup we can have is a hemispherical porous coated stem with facility for screw fixation. We go for press fit fixation. The most important points, if anybody asks me, in case of uncemented total replacement achieving good fixation, two things are very important. It is the press fit initial, that is called primary stability, and the second one is good contact with the viable bone. We need to have a viable bone for osseointegration to take place. But here one has to understand the difference between cemented and uncemented. In case of uncemented, for good bonding and bonding, you need exposed cancellous bone. Whereas in the case of uncemented, you don't need to expose the cancellous bone. So it is bone preserving in fact. A bleeding cortical bone is good enough for osseointegration. You don't need to expose the cancellous bone. So please try to remember this point. And other interface, I'm sorry about the spelling mistake here. Instead of PHAS, it should have been phase. Dynamics gap should be less than 0.5 millimeters, and the motion between the implant, the movement between the implant and the bone should not be more than 50 micrometers. Otherwise, it will end up with fibrous integration, which is not desirable. So you have basically two types of proximally coated and extensive coated. Again, I'm not going to go into those details. Uncemented, as I said, is bone preserving. If you take corail, for example, bone impacting, and this impacting technique will preserve the bone and at the same time blood supply also. So osteointegration is facilitated, and in the clinical trials also, corail has been there for the last, say, 15 years, and excellent outcomes because of this particular technical point. And on the uncemented side, you have the facility. If you have, say, for example, a metal shell which is fixed to the bone, you have facility for the interchange. You can have a ceramic if your cup is fixed very well. Most important in uncemented is you should not have too much of antiversion and too much of verticality. If you have that one after fixing, you think that everything has gone right, but after assessment fixation, you think that your cup is not in the perfect position what you wanted, in which case immediately you can switch over to a cross-linking poly instead of going for ceramic. Ceramic is not good if your cup positioning is not good. So this facility is not there in case of uncemented. Similarly, liners. If you take poly liners, you have got so much of variety here. A neutral liner is there, lateralizing liner is there, phase changing liner is there, elevated cups. So you all these facilities. If you have metal shell fix, if you have slight aberrations in the fixation of a metal shell, you can compensate that for going for one of these ones. This facility again is not available for you in the case of cemented. And another point here in relation to these liners itself is, if you are going for revision for some reason and your cup is not well, and stability of the hip is a bit affected, then you can think of exchanging the liner without disturbing the base, that shell which is well fixed to the bone. Whereas in the case of cemented, you have to take out everything, and in the process you are going to lose the bone also. So these are some of the advantages of uncemented technique. If you talk about other points which are superior, uncemented is superior, minimally invasive technique. So cementing is a cumbersome technique. You need to have good access to the bone to get optimal cement mantle and good fixation which will last for a long time. With minimally invasive techniques it is not possible. Similarly, short stems, you need to have at least 100 millimeters, that is 10 centimeters length of the stem for good cement fixation. Whereas short stems, they are always shorter, they are meant for fixation in the metaphyseal area. And if you are wanting to go for a short stem, again you have to depend on uncemented technique. Constrained liners, they put a lot of stress on the interface, and cement is not going to withstand these forces. So whenever you need to go for constrained liners, it's always better to go for uncemented stems. In osteoarthritis situations, for example, again uncemented has to be chosen, because if you try to go for cemented, the cement will ingress into the fracture site and that will end up in non-union. Osteotomy might, for the same reason, a fracture situation also. Similarly, in the acetabular fractures, whether primary or secondary hip replacement, in the primary case there is a fracture, in the secondary case many a times you will have non-union segments, so better to go for uncemented. And in case of division situations also, uncemented is better because the bone quality is a different day, there will be perforations, screw holes, and even if they are not there, you have to be aiming many times for distal fixation. When you are thinking of a distal fixation with cemented, try to understand, you will never be able to get pressurization on the cement and a good cement mantle. So again, you need to think of an uncemented stem, which is much superior than your cemented. So in these situations also, uncemented is superior. Avascular necrosis, PZ, because it is very difficult to get a bloodless feel for good cementing. In all these cases, these are all likely to bleed. Continually, whatever you do, hypotensive anesthesia, you can use adrenal, mixed saline swabs, whatever you do, there is going to be some amount of bleeding out, and then your cementing may not be good. This already I said. Revision situations also we talked about. And some of these disadvantages, as I said, bloodless feel you need to have in case of cemented. Cement pressurization, it is technically demanding, cementing technique. Of course, there are masters who can do wonderful job in cementing, but all cannot. Uniform and homogeneous cement mantle is mandatory and time consuming. You have to wait until the cement sets, so you have to spend with some time. Whereas in the case of uncemented, if you are very well experienced and you have templated in advance, it is a quick technique. Some people can do total replacement in just 35 minutes, 40 minutes also I have seen. So that is the advantage of uncemented. And over that you have these problems with cemented DHR, monomer related circulatory collapses. I have seen a couple of them when I was in England. And then embolic manifestation. In the process of pressurization, you can induce emboli, which can cause problems, particularly in those individuals who are compromised or have pulmonary means. Other disadvantages, these are known already. Cup failure rate after the first decade, revision rates are quite high, radiological revision evidences. These are all studies have quoted all these things. These are not my points. And if you see at the survivorship, uncemented overall, 95 to 100% mid to long term survivorship, whereas cemented, here the figures will speak, 94% at 10 years, 85% at 20 years, and 68% at 30. So in summary, I am not saying that cemented is bad, but you have to choose. For elderly people, osteoporotic bones, still a good cementing technique will give excellent outcomes. Whereas younger subjects who are heavier, particularly men, post-traumatic, post-surgical situations, is always uncemented is the best way of dealing with the problem. Thank you very much.
I will interact with you and I will try to question whatever he said with some evidence from the literature. So first of all, how many of us are hardcore hip surgeons and how many of us do 50-50 cemented, uncemented, 60-40, 40-60? So how many of us sitting here are cemented hip surgeons? None, is it? When he gave the talk, believe me, I'm a hardcore uncemented, but my talk is on cemented, and I will justify that the cemented hip replacements are no less than the uncemented hip replacements. So I would like to start by first thing, if there was no cemented hip replacement results shown by Sir John Chandler in 1964, he made his patient walk on the stage. Hip replacement surgery is the third best surgery in the whole of medical science. First being the cataract, second the heart, and third is the hip replacement, which can improve the quality of life. Sir John Chanley and Becky from Norwich, they showed that the cemented hip replacements giving excellent results. Now, first point, let's start. As far as the acetabulum is concerned, I agree with you that yes, nowadays the results have shown that there are better fixation techniques with an uncemented than with the cemented, because you can't pressurize the acetabulum as well as you can pressurize the femoral side. There is no pressurizer sort of available for acetabulum. So I would stick to the femoral stems mainly. You mentioned that the patient has got a higher incidence of cement reaction, like embolic phenomena, which is called critical bone cementing syndrome. So it can be hypoxia, it can be arrhythmia, it can be cardiac arrest, it can be hypotension, one or all. How many of us agree, yes, there is this critical bone cementing syndrome? Thank you. So even I also have experience, but if you see the literature, enough evidence. Sir, paper by Pitt, he's from Finland, and he won a best award also, Sir John Chanley Award, and he has shown that with the modern cementing technique, he has done an RCT, uncemented hip, cemented hip with a conventional technique, cemented hip with a modern cementing technique. And